Welcome, everyone, for attending today with the HHQI Underserved Population Network. We appreciate you taking time out today for our presentation. Do want to make sure that you did see the notice in the chat function. The handouts are posted on HHQI, and you can download this from the site that was posted. Today, before we get started on today's presentation, I do want to give a little plug for our session that we had 2 weeks ago on the 12th, Managing by Data. It was an excellent webinar session that included about how to capture CASPER data, how to access it, and it's an excellent presentation, and it is recorded and now posted in the Underserved Population Archive. Next slide, please. We're very pleased today to have Diane, who is a disability subject matter expert for Delmarva Foundation. She's providing technical expertise on disabilities, self-direction, individual budgets, and community waiver programs to state governments. Concurrently, she works with the American Network of Community Options and Resources as their liaison to the state associations across the country. Prior to her work, she was appointed by Maryland's governor as the Deputy Secretary of Maryland's Department of Disabilities. In that position, she oversaw the development of Maryland's state disability plan, covering a wide array of issues including children and families, long-term services and support, employment and training, housing, technology, Medicaid, transportation, and emergency preparedness. She was instrumental in initiating numerous policy shifts that resulted in increasing person-directed support and other levels of inclusion of people with disabilities in program evaluations and quality improvement. She was the CEO of a statewide association of community organizations that support people with disabilities and their families for 16 years. During that time, she was the principal legislative advocate on behalf of Maryland's programs and was the leader in the very strong collaborative growth of the disabilities programs experienced in the state. The first decade of her career was devoted to building a community agency that supported people with intellectual and developmental disabilities and their families, including many who were deinstitutionalized. Her career gives her the unique perspective of private community agency, the CEO of a statewide provider advocacy organization, and as a cabinet-level governmental official. She brings her extensive knowledge of the disability community, her demonstrated track record of innovative problem-solving, and lifelong commitment to creating an improved capacity in the systems that empower individuals with disabilities to achieve their personal and professional goals in the communities where they live. She holds the Master's of Education from Johns Hopkins University in Severe and Profound Disabilities and has a long history as working for an advocate for people with disabilities and nonprofit management. So I welcome all of you today, and I welcome Diane.
Well, thank you, Misty, and welcome to everybody on the phone. Today we're going to talk about people with disabilities as a health disparities population. When I first was asked to develop some background information on this topic, I myself did not realize exactly how people with disabilities fit into the health disparities framework, and discovered, in fact, that people with disabilities have become the predominant subpopulation in the disparities work being done and being viewed today, yet many of our health professionals are not aware of disabilities as a subpopulation. At the national level, we found that prior to the last couple of years, disabilities was expressly excluded in a number of research efforts that were undertaken, for example, so that the information and the data that we have available to us today is very scattered and very, very sparse. So it's a very interesting topic. Without further ado, generally speaking, who are people with disabilities? When we look at people with disabilities, the health Disparities report from the ARC defines people with basic activity limitations or problems with mobility, ability to take care of themselves, navigating their domestic life, activities that depend on sensory functioning such as hearing and vision, complex activity limitations experienced in work, community, social, and civic life. Couple of examples to give you, and I'm not going to read these, but just so that you understand, people with disabilities are of all ages, all ethnicities, races, nationalities, people who are elderly, people who are in the middle of their life, may have multiple chronic conditions, people who may have sustained a traumatic injury prior to the age of 65, not yet considered elderly, but nonetheless having a permanent disability. People who may have experienced lifelong medical problems as a result of disease or other kinds of conditions that affect their ability to function independently. And also children, of course, can have disabilities and, in fact, be among those who are experiencing health disparities. Disabilities today is a new standard of determination for federal data collection systems, and it is done by a self-disclosure questionnaire. So a person will answer the questions: are you deaf? Are you blind because of a physical, mental, or emotional condition? Do you have difficulty concentrating, remembering, or making decisions? Do you have serious difficulty walking or climbing stairs? Difficulty dressing or bathing? Or difficulty doing errands by yourself, such as visiting a doctor's office or shopping. These you might recognize as questions that could be much deeper with regard to activities of daily living. However, these are reduced to fairly simple questions that people would self-disclose on their own. People with disabilities often do not receive basic primary and preventive care due to a lack of accessibility. And when we speak of accessibility, most people think of ramps, and they think, well, all of our buildings now have ramps or we have elevators, but we don't often stop and think about the accessibility once inside the doctor's office. Scales are geared for people who can stand. Dental care is very challenging for individuals, especially with cognitive disabilities, who might experience extraordinary fear, apprehension. Women, with pelvic exams, are the exam tables accessible if you're a woman who uses a wheelchair? We found in the data that we reviewed that many women who use wheelchairs do not get to a gynecologist because the exam tables just aren't accessible. X-rays, including mammograms, all types of physical examinations, colonoscopies, vision screenings, and so forth. If you can't access the equipment, then the office is not accessible. I would say further, there can be, for an individual who is deaf, the lack of an interpreter available who might be able to communicate with American Sign Language, so that the individual using sign language has someone to hear what the doctor's comments are directly, as well as individuals who may speak a different language, the normal types of issues that people with ethnic and racial disparities experience. Often people with disabilities experience prejudice and discrimination as well. It's not uncommon for a physician to say that they don't have expertise in a particular area. They may not be comfortable treating a particular disability. They have difficult time understanding some of the individualities that occur in cognitive disabilities, so that people with disabilities have a difficult time sometimes finding the care that they need as a result of the disability. Generally speaking, it is considered today that people with disabilities make up 20% of the general population, and this is across all ages. Further, people over the age of 65 have an age-acquired or lifelong disability. 39% of those individuals have disability. So it's a huge subset that we look at when we talk about healthcare interventions. By identifying the specifics of a particular disability, there's a real opportunity for us to improve health and reduce the expensive cost of primary and acute care. But again, usually it's an afterthought as to how to intervene for an individual who has a disability. When we look at some of the research that has been conducted to date, and this is, albeit it's July of 2011, but it is the most current information we were able to find collectively. We have, that disability is the first grouping, and we've measured the degree to which people with disabilities are more likely to be sedentary and more likely to smoke. They are among the highest group if you look in both sedentary and in likelihood of smoking in all of the disparity groups that are considered. And right off the bat, you can see where this calls many questions to mind. Obesity and diabetes, again, higher than any other minority group, significantly so. Let's skim that data. They're more likely to suffer from heart disease than any other minority group. And again, look at the incidence, the differences there, very high. They're less likely to have access to regular medical care. And we do believe this is changing now with the implementation of the Affordable Care Act. One of the primary reasons people did not have insurance who had disability was the prohibition against pre-existing conditions, which of course is no longer an issue. Also the lifetime cap that most health insurance plans had in place previously, now that is gone. So we expect that most people with disabilities will now be eligible for insurance, and these numbers will change dramatically. This graph gives you an idea of the percent of people with disabilities by state. And, I'll let you scan where your state may fall. So it would give us, if you look at the prior data that we just presented, it gives us a great call to action, I think, regardless of which state, that if we can do something to reduce healthcare costs for people with disabilities, we're going to be benefiting the system overall. I'd like to spend just a few minutes talking about people who are duly eligible for both Medicaid and Medicare. I realize that the QIOs work with the Medicare population, but increasingly people with eligibility for both Medicare and Medicaid are entering into the work that we do in the quality improvement organizations. Who are the people duly eligible? They can be seniors over the age of 65, as well as people with disabilities under the age of 65. And this gives you an idea of the number. We're talking about a subset in this country of 9.1 million people. So that is a lot of people. For those of you, and forgive me if you have a familiarity with Medicaid and Medicare, but I'm going to just briefly go over this to frame the context of this discussion. People who receive Medicaid and Medicare have two competing insurance coverages, more or less. Medicare provides acute and primary care, while Medicaid primarily provides for the long-term services and supports. Data shows that people duly eligible are among the sickest and the poorest among all beneficiaries. Medicaid eligibility is based on income as well as categories including disabilities. Any person receiving supplemental security income is automatically eligible for Medicaid in states, as well as an indigent, that's the test of indigence, as well as other individuals who may be indigent. They also represent a small share of enrollment, but a large share of the spending due to the health care needs. So another reason why we want to look at individuals duly eligible. Medicare is the primary payer for medical services, covers hospital costs and some out-of-pocket expenses. Medicaid, however, covers additional benefits such as dental, vision, and long-term care, as well as the out-of-pocket expenses. The Medicare does not cover that. People who are fully eligible for both Medicaid and Medicare, they have all Medicaid benefits and coverage covered, dental, vision, other services, long-term care, nursing home stays, home and community-based services, where Medicare coverage is really limited. People who are partially dually eligible, Medicaid pays only for the Medicare premiums and cost sharing, and the assistance level is based on financial needs. So who are these folks, the dually eligible? We have, again, keep in mind, it's 9 million people across the country. We have 56% have income levels below level of poverty, way below level of poverty. 69% are female. 45% represent a racial or ethnic minority. 50% are in fair to poor health. 57% have cognitive mental impairment. These would be individuals who have developmental disabilities, behavioral health diagnoses, and people who have had acquired traumatic brain injury or acquired brain injury or traumatic brain injury. You get the idea. And also 16% are receiving long-term care benefits. So it's a huge, hugely dependent subset of the population. In Medicare enrollment, 45 million people were 20% of the Medicare enrollees total, spending 32% of the funding that was actually encumbered in Medicare. And in Medicaid, 15% of the individuals are dually eligible, and their expenditures were representative of 39% of all Medicaid costs. So you can see the motivation that both the federal government and states have to provide better care, integrated care for people who are dually eligible. Medicare expenditures for individuals who are dually eligible are shown on this graph, and you can see 27% inpatient hospital care. I know that you've had a lot of conversations about reducing the rate of hospital readmission. People with disabilities tend to have a very high readmission rate for a number of reasons, but not the least of which a lack of understanding interventions that might prevent that inpatient hospital stay. So that's a very good reason why we should be focusing on this particular population. When we look at Medicaid expenditures for people who are duly eligible, $57 billion going into institutional care. That's your long-term care side. Nursing home, institutional care, you have an additional $31 billion going into home and community-based services, which states would be providing through 1915C waivers. Don't want to get too technical on the waiver stuff, but there's a lot of people in the community system that are receiving services that are also eligible for Medicare as well as Medicaid. So again, the numbers are huge. So what are the health concerns for people with disabilities? We reviewed some high-level overview of what some of those disparities look like, and we've also talked about people duly eligible as a subset of the population of beneficiaries who are at a high risk for high cost, high users in our healthcare system. We find people with disabilities more than twice as likely to have diabetes as those without disabilities. They are 10% more likely to have hypertension than adults without disabilities. People with chronic mental illness, data shows that they die 25 years sooner than people without mental illness. 60% of people with chronic mental illness die from preventable diseases such as asthma, diabetes, cancer, etc. I'll share with you that the data that we see dealing with people with a psychiatric diagnosis and healthcare and disparities, it's all over the place, and there's many reasons that we can speculate. There is a very high use of tobacco among individuals who have mental illness, and there are lots of efforts specifically targeting people with mental illness to reduce and eliminate smoking. We also find a high percentage of individuals who are homeless as having a diagnosis of mental illness. And one study that I reviewed of individuals who were homeless and their rate of hospitalization and readmission, if you can imagine, if a person is homeless, they're released from the hospital, they don't have a home. So they basically are released to the street. it's no small wonder they show up again within a month in the emergency room with a problem because they have not had an opportunity to recuperate from whatever the hospitalization was in the first place. People who are deaf or hearing impaired are 3 times more likely than hearing people to report, say, poor health. And again, there's a huge issue with the provision of American Sign Language in offices of physicians, dentists, specialists, and so forth. There is a lot of information available under the ADA, the Americans with Disabilities Act, basically requiring any business to provide an accessible environment to individuals who have disabilities. There have been lawsuits against physicians for not providing a sign language interpreter for individuals who are deaf. Those have all been left in limbo pending with the Supreme Court and so forth, because obviously there is a huge expense incurred on the part of anyone who would provide a sign language interpreter. At the same time, it remains an issue, and we find in communities where there are physicians who have a high number of patients who are deaf, they are providing the sign language interpreters, and those individuals who are deaf flock to those particular healthcare practitioners. Communities around Washington, D.C., we have Gallaudet University, which is the national college for individuals who are deaf, as well as in states near schools for individuals who are deaf. We find those communities have usually physicians that have carved out a practice where they do provide full accessibility for those individuals, and those individuals would have better, more routine care provided than if they were not able to communicate through the use of an interpreter. People with intellectual disabilities, people with developmental disabilities, they experience disparities in oral health outcomes, which obviously is a key factor to life expectancy. There's lots of reasons for that, but again, there's a shortage of practitioners, there's a lack of understanding of the best way to treat an individual who has a high level of anxiety, but we are finding that there are some tools available, and we're going to talk about some of those as we get through these. Solutions for people with chronic mental illness, something to give consideration to. We have found that treating tobacco dependence is effective in patients with severe mental illness. There are interventions. It does not change the mental state of the individual. Withdrawal is withdrawal. However, with the proper interventions, there can be improved health quality introduced. For people who are deaf, communicating with deaf or hard of hearing individuals, obviously a trained sign language interpreter is needed during medical visits, just like an individual who does not speak English as the primary language, and physicians and other practitioners are discouraged from using family members to provide interpretation of instruction. The same is true for individuals who use sign language. We also find now there's a tremendous growth of technology that's available. There's video phone, video relay interpreting services. Information can be faxed to the patient. Text messaging is widely used by individuals who are deaf, as well as instant messaging. There also remains the old TTY, TDDs, and every state has a nationwide relay service, which is service in every state that is dialed where an interpreter will, for a person who may be deaf or unable to speak orally, they can communicate with a device with an individual who will then place the phone call for them to a hearing person or speaking person and translate so that the individual can have the opportunity to use the phone system. That's available for everyone and can be made known. Decreasing obesity among people with intellectual disabilities. Again, studies show that people with intellectual disabilities who become more active when health personnel and caregivers work together to encourage healthy lifestyle changes. We do have the study noted at the bottom of the slide, by the way, if you want to see more of the data that has been pulled together for these. But again, a simple intervention, joining a health club, program at the Y, things of that nature. It's more of encouragement and friendship to provide the opportunity for individuals and encouragement to them to participate in a healthier lifestyle. The national, cultural, and linguistically appropriate services in health and health care. This is part of the Office of Minority Health. It is known as Clas, C-L-A-S, and it is available. The standards are available at the website that's noted on the slide, and I know you have this, the slides available to you. It is intended to advance health equity among all disparity groups, including people with disabilities, improve quality, and help to eliminate the health care disparities that exist. The national class standards are listed here, and there are several standards that if the suggestion is that if an organization were to take these standards to heart and look at ways to provide information to the organizations you might work with, for instance, on informing individuals on the availability of language assistance, providing easy-to-understand materials and signage. Some of this seems simple, but lots of healthcare practitioners are busy, don't necessarily think of these things individually, and we could provide a great service by providing those things. Additional resources that are available, and I would encourage you to click on these links and take a look at them. This will show you some of the data, some of the studies that have been done, some of the solutions that have been tried, and give you an idea of a way that you might affect change within your own organization. We have the fact sheets that are available in the underserved populations, promoting healthy lifestyle for people with disabilities, tips for older adults. Almost every state now has an Aging and Disability Resource Center, an ADRC, which is to be the one-stop point of entry, if you will, for all information. These organizations often have a lot of information that can be helpful as well. And I think I've gone on too far here.
No, that is perfect. We do have, you can type in any questions that you have for Diane in either the Q&A box or the chat box. And while we give you some time, I'm going to come back and ask a couple questions or highlight a few things. I was very interested in an earlier slide that you had, Diane, with the states with the disabilities, and we could see the color coding. And it very much, the states that were in the South and in that mid-section of the country, there we go, are also the same states that we find are lower outcomes, especially with cardiovascular health. Some of the stroke belt states, the states that find it extremely difficult because of lifestyle choices and for a variety of reasons in the South. But it really does very much mirror that. So it was kind of a standout and aha moment when I looked at that slide. Anything that you might have to add to that?
Well, I think that if we look at data across the country for health disparities, and that's what this, this slide is looking at disabilities by state. If you look at health disparities by state, you do other comparisons. There are some states that are touted as being healthier for a number of different reasons. They can be either the age of population, younger generations, there's a longer warm period, there's lots of different reasons. I think that it comes down to healthy or unhealthy lifestyle choices in so many ways, though. And as you mentioned, are we consciously, as a society, motivating our citizens to be active? Are we motivating them not to smoke, not to indulge in a diet that's high in fats and sugars, that sort of thing? What we look at with people with disabilities, again, people don't often think of an individual who has a stroke specifically as having a disability, or they don't, it's a hidden disability, such as epilepsy, for example. They don't think of it because they don't see it necessarily, or they're not looking at seeing a wheelchair. But people with disabilities come in all shapes and sizes, and because of the inaccessibility of the healthcare system in general, they often experience the chronic health conditions 2 or more because of their lack of ability to access good health care. If you look at the population of people who are in the home and community-based waiver system, there it was, this slide, there is $31 billion. This is just looking at expenditures. But that home and community-based service system, that system is funding waivers in states, waivers to that institutional level of care, which is defined as nursing facilities or intermediate care facilities for people with intellectual disabilities. But the HTDS system is serving older adults in our community in their own home. It's serving people with intellectual and other developmental disabilities. It's serving children who have mental health diagnoses, serving individuals who have traumatic brain injury, people who have HIV, and children and adults with autism. That piece of the system, the data will generally show that those individuals have better access to health care than people who live at home with families who are not in a waiver program. And I believe that reason is speculated is because they get health, kind of a health home sort of care coordination that occurs where somebody in a program is trying very hard to integrate their health care across all different healthcare practitioners so that they get good outcomes. And I think that that's a key that the data points to. If we can figure out a way to integrate people's health care, then we're going to see better results. Other questions? Misty, are you still on the line?
Well, I'm going on and on, but I'm on mute. Thank you.
Oh, no. Okay, that's fine.
Thank you. Yes, please post any questions you have. We do have a question that has come in from Haylene about can we post slides on our website for our providers. And we do have the handouts that are available already up on the HHQI site under the Up. There are I believe three slides on each page. So if it's something that you are interested in having just like one slide per page where it would be very large and easy to read or something to that, just send us your email and we would be very happy to provide that for you. I think the information is very interesting. We as home health care providers, we just are accustomed, and I think some of the comments that Diane mentioned just a few minutes ago about we look at stroke patients as a stroke patient, not so much as having the disability. And we're just used to working with disability patients that we sometimes don't stop and think. We do think about how are they getting to their physician practices. Can they have transportation, which is a huge issue, especially in a rural setting, which I have as a question and comment. But I think thinking beyond getting into the building, I think those were excellent slides that we don't stop and think about.
You ready for a comment from me?
Yes, please.
Okay. I wasn't sure if the question is done. Well, I shared your astounding response to the accessibility of the actual practitioner's office because when I did the research, it just didn't occur to me how much of an issue this was. There are so many other areas of disparity that I discovered in what I was looking at. For instance, people with disabilities are at a much higher risk of violence, both domestic violence and violence in the community, in part because they are perceived as easy targets and also their inability to get around easily. We are just now, as a country, starting to look at disabilities as one of the subsets for disparity. So I think the next couple of years, as we look at the work being done in CMS and other places, we're going to see many more things revealed. As for transportation, I know for individuals who are dually eligible, every state is supposed to be providing medical transportation for medical visits through Medicaid, and that should be an option that's available. I do know those systems often are fraught with issues and problems, but nonetheless, that is an option that is available in most states. And I think that the more awareness that we have as a system, the better the outcomes are going to be for people with disabilities eventually. Finally, I would share, if you go back to the data that shows that 39% of people over the age of 65 have a disability, either one that they had prior to 65 or one that they acquire as a result of aging. As our population ages, we are going to find more and more people who will find themselves in that category, and I think because the predominance of consumerism, those individuals are going to create a great strain on the system, but at the same time perhaps highlight and advocate within the system for better accessibility for the services.
Wonderful. Could you elaborate on who, I know you said it's state specific, but with every state with transportation for their medications, so where would we as an agency, if we're not sure where to start with, what should we call our local MA provider? Where would we start to try to find that information out?
I would start with your state Medicaid office and simply ask who the vendors are in your particular state who provide transportation for Medicaid health-related services. There may be more than one vendor. Most states will take a regional approach to that, and like I say, it's not always a perfect system. When I worked with our state in government, we certainly spent a lot of time identifying what the root causes were for some of the problems and trying to address some of them. At the same time, there are many systems that work well. So I would start with your Medicaid office and ask where the vendors might be and how you might access that transportation. The other suggestion would be to contact the area office on aging in your particular region. They may have that information as well.
Okay, and I can throw in probably another resource perhaps in your area. I don't know if it's completely in the United States, but a lot of areas now have what's called the 211 phone number to call for community resources. And I know in our area it's through the United Way, and transportation was one of those avenues that they would help arrange as well.
Good point.
I have two good questions for you. First from Vicki. Can you elaborate on the waiver program?
Yes, you're thinking of the 1915C waivers that I mentioned?
Yes, I believe so.
The 1915C waivers, and I'll try to keep this concise. If you want more information, there is a lot of information at cms.gov. Just go to Medicaid. Waivers are funded through Medicaid, and they are in every state. Every state has many waivers, not just one in most cases. States have been given the option by CMS to waive the eligibility requirements for certain criteria to provide services to people instead of in an institutional setting, to provide them in the community, hence the name Home and Community-Based Services. They are authorized under Section 1915C of the Social Security Act, and they provide states with an option to author a set of services that they would then submit to CMS for approval, and CMS would say, yes, you can do this, or you need to tweak it, but basically every state offers waivers that allow them to serve people in communities where they live rather than institutions. For individuals who are elderly, I think almost every state has an older adults waiver. I'm going to say they all do. I'm not sure of any that don't. And basically the services available under an adult waiver would be any services that create an environment whereby the elderly individual can stay in their own home rather than go into a nursing home. And that's going to look different maybe for each person, or different from groups of people, but primarily that it's going to look in some cases like home health care. It may be providing transportation services from time to time. It may be providing some socialization opportunities for younger people who might be on not the older adults waiver, but the autism waiver, or the waiver for individuals with intellectual or developmental disabilities. Those waiver services provide group home services, supervision, individual support services, things of that nature. And each waiver is tailored a little bit differently. That could be another presentation in and of itself. There's a lot of information about that. It's a very complex system, but it does allow states to provide services in the community.
Absolutely. Thank you. That was a great overview. And each state is very unique, as Diane said, and they are trying some innovative ways to work and coordinate services too. Many of you may have not been present on our March 13, 2013 teleconference call, which is recorded, and that is March 13th, and it's called Coordinating Medicare and Medicaid. And we had two excellent presenters, Robin Wagner with the Louisiana Office of Aging and Adult Services, and Allison Bourgeon from the Louisiana Department of Health and Hospitals. And they talked a good bit about what the waiver programs are, and about out-of-the-box approaches, and how home health can work, and how we need to look at our dual eligibles. And even though we're getting Medicare as a payer initially for the acute episodes, we need to be thinking long-term and getting them onto these waiver waiting lists, or getting them signed up for the programs that they need. So that could be is a recorded webinar. It's not a webinar. I believe that is an audio conference, but you can find that on the app under the archives. Our next question, thank you again, Diane, excellent explanation. Our next question comes from Linda. Can you talk a little bit about best practices to engage the disabled person?
Oh, absolutely. Again, depending on who you're working with, who your clients are, who your beneficiaries are, there are a number of community organizations that are available that work with folks on a regular basis. If you were to contact your state Medicaid office, for instance, you could get a list of providers that support people under the home and community-based waivers. Those organizations would be places where you could do outreach, you could send flyers, information, etc. You could contact what we call consumer groups. They could be clubs or support groups for people who may have psychiatric diagnoses, people with intellectual and developmental disabilities. Organizations such as the ARC is a great one that I think almost every community in the country has an ARC. There are peer support groups in the mental health system that support individuals, parents groups, if you're looking at children who may have autism or other kinds of disabilities, but there's a number of outreach services that you can do that way. There's also a website, and I don't, I'm looking at the slides here. I don't know that it's on the slides right now, but I can provide to Misty a link at the federal level that will break down resources, organizations by state that are known to work with people who have disabilities. And that's another source of information for folks.
And I have maybe a different slant of question related to that too. Absolutely finding the resources. And I think sometimes in home health, we rely on our social workers, and in some of our agencies, they're small, they might be rural. It may be difficult to even have the social workers even on staff, or you have them on a per diem basis. So accessing and figuring out what resources that you have and being able to share. But now from a different slant, Diana, I don't know if there is an answer to this or not, but if for a patient, and disabilities you've already showed us are all over the board as to physical, cognitive, et cetera. But as we try to engage patients into being more self-managers and into doing more patient healthy lifestyle changes, is there like common personalities or any kind of common, I'm not sure what the word is I want to use, of how we might engage this population that has a disability? Because like you said, the difference of us seeing a wheelchair versus them seeing a wheelchair, or the community seeing a wheelchair versus a healthcare profession. Any thoughts about engaging them for outcomes?
I would say I don't have an answer right off the top of my head that's concrete, but I will say that there is a great deal of work being done right now with applications, technology applications that can be used on a smartphone or an iPad that have worked very well for individuals with cognitive disability. It's a combination of words and I say video, something like a YouTube presentation on how to do something, such as taking medication or doing any type of routine task that promotes good health practice, and also using different clicks, if you will, with an application that people are finding very successful. So there may be some resources in that venue. Again, right off the top of my head, I don't have any specific examples I can share with you, but this is a resource. But I'm aware of a lot of technological intervention that's occurring that is being very, very helpful to people. One example, for instance, you could call, the remote monitoring that is available today is not only used in a nursing home setting, but also individuals with disabilities are opting to use remote monitoring because they see it as a way to afford them some privacy. A person with cerebral palsy, for instance, who needs all types of personal attendant care, perhaps doesn't need a live person in their apartment overnight. If they have access to remote monitoring, they could perhaps develop a protocol whereby they would be safe on their own as long as there's a backup system. So technology is changing the way that we're supporting people as well, very, very rapidly.
And those were great insights, Diane. And we see that in a lot of research, and especially with people in that middle age group, which you showed us on the slides. So we do have a lot of dual eligibles. We also have a lot of disabilities in that 40-ish, 50-ish to 60 range even. And those people are more computer savvy. More of those have phones that text, that smartphones. Are used to watching YouTube videos and like that type of education. And we're finding disease management more effective in some of the studies for that population. So it doesn't matter that they have a disability. We can leverage that equipment. And a lot of our home health agencies use telehealth or as a mechanism to provide a care or to supplement the care that they're doing. So those are good at recommendations.
Some of the original, and I don't see it on the slides that got posted, but I know we've got a slide that I'll make certain you have that posts the website that the Disparities National Coordinating Center developed, where we have a lot of resources, not only for disabilities, but all disparities, and you may be familiar with it already. But that link also provides a tremendous amount of information, including tips for talking to people with disabilities, what to say and not say, how to engage, and things of that nature.
Great. I'm going to actually have you go ahead and change the slide back to the HHQI resources, and we'll kind of move to that area. And I have a couple more resources. And I will send out to all of the participants in the next day or so any additional materials that Diane will send us and a couple links that she talked about today. I'll make sure that I include for you as well. In the Underserved Population Best Practice Package we have posted, there is a disability section on page 47, but throughout in that package, Diane talked earlier about talking about the Clas, and there is a lot of information about Clas, cultural competencies as an organization, and lots of tools and resources for people that might have language disabilities as well. So there is a lot of information there. One other resource I did not have posted here, but because of your presentation, Diane, when you talk about smoking and cognitive issues, in the cardiovascular health, Part 2 Best Practice Package, that's cardiovascular health, Part 2 Best Practice Package, on pages 53 to 54 and 75 to 76. And that was 53 to 54 and pages 75 to 76. There is a section where it talks about smoking cessation and how it does affect the cognitive population and some strategies that you can work with them in smoking cessation as well. Well, if you have any more questions, do go ahead. I just want to make sure I haven't missed a question because they were excellent questions. And if you needed the link, thank you, Misty Dyke, for posting the link for the cardiovascular health best practice package on there. Meantime, I'm going to go ahead and have Diane change to the next slide for us, and we'll do a couple announcements, but we'll still watch for questions. Our next Underserved Network call is March the 12th from 3 to 4 p.m. It is going to be Underserved Populations, a Managed Care Perspective. Marian Essey, she is the Director of Clinical Community-Based Services for the University of Pittsburgh Medical Center, the Insurance Service Division, is going to talk about how you can work with your managed care in addressing the underserved population. She has extensive background from home health as well as within the insurance industry. You can register now. There's a link within the slides, or just go to, you're going to be directed there actually at the end of today's webinar. You can sign up for that presentation. Next slide, please. Oh, and and as we get ready to turn the slides, just to let you know, too, that you do have to be registered to HHQI and log in to access the campaign website, but it's free, and you don't have to be a home health agency. You would just answer no if you're not. We have providers that are hospital-based, community-based. We have several QIOs that are on the call today, but all of our materials are free for you to utilize. Do connect with us. We'll go back one slide, sorry. I'll need it as a reference. We do have connect with us on Facebook. Right now with Facebook, we've been running Heart Awareness Month, and we've been doing a simple tips for Heart Healthy every day this month. So sign up and check those out. You are welcome to repost those to your site. We have a Twitter account as well as LinkedIn. And LinkedIn, we provide a variety of articles, comments, and different information throughout the week that are relevant to your day-to-day practices and populations. We have an HHQI blog you can sign up for, and it'll come through your email. It comes out once a week on relevant topics and looking at some research articles that are around. HHQI discussion forum. If you want to ask a question, you're welcome to ask other agencies a question and get a discussion started. And then we have live chat. If you've not participated in a live chat, they're great fun, great information. Our next one is March 14th, and if you use the link in the handout or go under network, I believe, you can sign up for a reminder, and it'll just send you a reminder. There's no audio. You just chat in what you have concerns with, what you're looking for, resources, and everybody shares information, and it's great fun and a lot of information. Okay, and the next slide, please. And I will tell you why we're getting our slides changed. At the end, you will be redirected to an evaluation if you don't mind completing that for us. And I think our last slide is just a thank you very much. We appreciate. And let me take a look to see if there's any additional questions. There's just a link to the handout. And I believe that's all the questions we have, Diane, for you today. I want to thank you and see if you have any last words.
I think this has been a pleasure, my pleasure to do. I did note, but I can't find it now, that there was one individual that privately sent me a question, and I wasn't able to get to it because it was hard to read back and forth. But if you would be, that person could certainly get in touch with me, could email me or call me, and I'd be happy to answer their question.
And that actually goes for anybody that's on the call. If you have a question that you think about later, you're welcome to contact Diane or contact us through our HHQI mailbox, and we'll get it to Diane. We would want to be able to provide any answers that you might need. So again, thank you, Diane. This presentation was excellent. A lot of information. Absolutely, please, for anyone that's participating, can utilize the material, share the information. The recording will be posted in a day or two on the up page in the archive session. We hope you'll join us next month for our sessions, and we thank you very much.
Okay. Are you still there, Misty?